Happy New Year, everyone, and welcome to the Project Echo's COVID-19 Global Conversation Series. I'm Matt Bouchonville. I'm one of the Associate Directors at Project Echo in New Mexico. And today's session is going to focus on COVID-19 vaccine distribution plans. And we are joined today by Doctors Amanda Cohn, Aisha Khan, and Loretta Christensen. And we will be receiving updates today on vaccine recommendations, vaccine hesitancy, and we'll also talk about how the vaccine is being distributed through Indian Health Services. So a lot of important information today. Before we get started, we want to remind the network that we do have Spanish and French interpretation services available. So if you'd like to follow the conversation in Spanish or French, please click on the interpretation icon at the bottom of the screen, and you'll be able to choose your preferred language. You'll also be able to submit questions for our speakers today in either Spanish or French, and they'll be interpreted into English. We've had almost 1,500 registrants for today's session, and we're grateful for the time that you've taken out of your busy schedules to join us today. So thank you very much. I'm going to be co-facilitating today's session with the founder and director of Project Echo, Dr. Sanjeev Arora. Sanjeev?
Thank you, Matt, and thanks to all of you who are taking your valuable time to attend these the Global Conversation Series. The purpose of this series is to have people around the world be informed on the latest information on COVID-19. And of course, today's session will be focused to a large extent on the United States, but we hope there'll be many, many lessons coming out for all of you who are from all over the world. And thank you all for joining, and thanks to the speakers for accepting our invitation to host this session. Back to you, Matt.
All right, thank you, Sanjeev. And before we begin, we do have a few housekeeping items to review. So today's session will be recorded, and the video links and presentation slides from each of our series can be accessed on our webpage. So please note that it can take up to 48 hours before you can find that material on the website. Please note also that all of our participants today will be in listen-only mode for this session. And we do have plenty of time built in for discussion. So please submit your questions in the Q&A box at the bottom of the screen as we go. And you'll notice that when you submit a question, it will disappear from the Q&A box. That is because the questions are being cut and pasted into a live document that'll help us navigate the live questions as they're coming. So keep the questions coming. We are going to ask that you refrain from responding to other people's questions in the Q&A box, please. And then keep an eye on the chat box, because you're going to see a lot of resource links posted there from the Echo Digital Librarian. And then also you'll see links there for things such as the survey that we'll ask you to complete at the end of the session to obtain your CME credit and CEU credit. So I think we'll go ahead and do a brief round of introductions from our speakers as well, starting with Dr. Amanda Cohn.
Apologies, that took me a minute. Good morning, everyone. I'm Dr. Amanda Cohn. I'm the Chief Medical Officer of the Vaccine Task Force at the Centers for Disease Control and Prevention.
Thank you, Dr. Cohn. And how about Dr. Aisha Khan?
Everyone, my name is Aisha Khan. I'm an infectious diseases fellow and a clinical microbiologist, as well as a grassroots community organizer here in Houston, Texas, and I work at both UT Health as well as MD Anderson Cancer Center.
Great, thank you. And Dr. Loretta Christensen.
Morning, everyone. I'm Dr. Loretta Christensen. I'm the Chief Medical Officer for Navajo Area Indian Health Services.
All right, thank you, Dr. Christensen. And without further ado, I think we will move on to our first topic today, presented by Dr. Amanda Cohn, who currently serves as the CMO for the Vaccine Task Force and the National Center for Immunizations and Respiratory Diseases, or NCIRD. She's the Executive Secretary of the Advisory Committee on Immunization Practices, and has previously served as the Deputy Director of NCIRD's Immunization Services Division. Dr. Cohn came to the CDC in 2004 as an Epidemic Intelligence Service Officer and joined the Meningitis and Vaccine Preventable Diseases Branch in 2006, where she focused on prevention and control of meningococcal disease, both domestically and internationally. She's board certified in pediatrics and is a fellow of the American Academy of Pediatrics. She obtained her medical degree from the Emory University School of Medicine and completed a residency in pediatrics at Boston Children's Hospital and Boston Medical Center in Massachusetts. So thank you so much, Dr. Cohn. Over to you.
Good morning, everyone. I'm sorry for my, I'm trying to share my screen. Let me just make sure I have this right. Okay. Great. Can everybody see my screen?
Yes.
Okay, so good morning, and thank you so much for having me here today. I'm really grateful for the opportunity to share with you where we're at with vaccine implementation, as well as go through some of the very clinical guidance issues that have been raised over the last month. One of the key things I want to emphasize is that the clinical guidance around how to give COVID vaccines was developed with very limited data, but we don't want guidance around co-administration or time between COVID vaccines and different doses to limit vaccination. So we do want to make sure that we reduce any barriers to vaccination. So the COVID-19 vaccine guiding principles around distribution are to have efficient and equitable distribution so that we can get vaccines in arms as soon as possible, but also ensure flexibility. So within national guidelines, state and local jurisdictions should have the flexibility to administer vaccine based on their local epidemiology and demand. So we initiated vaccine administration in the middle of December. These are data as of yesterday, January 8th. And you'll see that we've given about over 6.6 million doses. Persons have received their first dose of COVID vaccine. However, you'll also see that we've had over 22 million doses distributed. And I'm sure all of you have heard on the news that there is a lot of concern around why we have so many doses out there that aren't getting into arms. And I'll talk at a very high level about a couple of these issues. One, we did anticipate that it was going to take jurisdictions a couple of weeks to extend and expand their distribution. There was very limited information about these vaccines available to them before they were authorized. And so this is an incredibly challenging in terms of understanding the ability to, in terms of storage and handling and how to make sure that we don't waste doses. And so there were a lot of challenges put on the jurisdictions in the month of December. In addition, to the fact that they're trying to implement this program under one of the biggest, well, the biggest surge we've had in the United States since this pandemic began. Thirdly, if you look at our doses by day, the holidays absolutely limited the number of doses. And so I do anticipate that the number of doses administered will start to increase now that we're through the holidays. These data are a couple of days behind. This is the number of reports of people who have gotten vaccinated, and it does take about 2 or 3 days to catch up for everyone to report the number of doses they've given. But even if we're doing better than how we did in the first couple of weeks, we have to be doing more. And the demand, especially in underserved minority groups who make up a large number of the healthcare workforce, is incredibly low, and it's concerning in terms of the amount of vaccine hesitancy and the number of individuals who do not want to get vaccinated. And so we have to both increase the number of doses we're given without leaving anyone behind. So we have to continuously go back and educate and communicate and engage groups that are concerned about getting the COVID vaccine, and make sure that they have an understanding and can be empowered to make the decision to vaccinate. This is a slide that goes through the various phases, and these phases were recommended based on the number of available doses that we anticipated would be available. So we started with frontline healthcare workers and persons living in long-term care facilities. This is the dark blue phase. And that was 1A. That's really who we were recommending getting vaccinated with these first doses. The number of individuals in these two groups did exceed the number of doses we thought would be available in December, but uptake among healthcare personnel in particular has been very low and highly variable, but very low. And so we have this additional number of doses. So in phase 1B, as you know, many jurisdictions are extending into already, which is a great thing. That includes other frontline workers, such as people working in public transportation, firemen, policemen, people who don't have the ability to control their interactions with the public and who have to go to work right now, who are keeping us safe, as well as 75 plus. That's an additional 40 million people, and we anticipated having enough doses available to vaccinate phases 1A and 1B in January. But given the low amount of demand, we're already starting to see jurisdictions and encourage jurisdictions when demand is not there to go ahead and extend to 65 plus. You can see these other two groups, the 16 to 64 with high-risk medical conditions and the 60 to 64 without high-risk medical workers, and those essential workers are a huge number of individuals. So really, we want jurisdictions to consider adding that age group, the 65 to 74-year-olds. We don't want it to be so hard to get vaccinated that the 75 plus or the 65 plus aren't able to get an appointment to get vaccinated because they're being because of the demand in these larger two groups. And so we are trying to see how demand supply matches with the 65 plus right now. So I'm going to talk a little bit about vaccination of special populations. Specifically, I want to address concerns and issues around should I as an individual get vaccinated, should my patients get vaccinated? And I will start with, there are very limited data on certain conditions, but what we do have are two large clinical trials that enrolled a high proportion of persons with an underlying medical condition, be that obesity, heart conditions, autoimmune conditions, HIV. There have been individuals with all of these underlying medical conditions enrolled in these clinical trials and followed from a safety perspective. There have been no differences in the vaccinated versus unvaccinated group in terms of imbalances, except for the imbalance of Bell's palsy, which is still, there were very few cases in either group. And so we're still watching that very carefully. But we don't have enough data to say this person with a specific underlying medical condition, there may be an additional precaution or contraindication. So for now, given that the benefit of vaccination is so high and we don't have any information about potential risk, we do recommend that vaccination be administered to persons with almost any underlying medical condition. And so as long as you don't have any contraindications specifically to this vaccine, which we'll go over to in a minute, we do recommend that persons with underlying medical conditions get vaccinated. These are especially important because underlying medical conditions put an individual at increased risk for severe COVID-19. And so these are actually groups we want to get vaccinated. I'm going to focus specifically on immunocompromised persons. This is a group that we get a lot of questions about. These individuals might be at increased risk for COVID-19. Our data do not currently, there are not data currently available to establish safety efficacy in this particular population of persons with immunocompromising conditions. As I said before, persons with HIV infection were enrolled, but not persons with very low CD4 counts. In general, our recommendations are that these individuals may still receive COVID-19 vaccine unless otherwise contraindicated, but these individuals should be counseled about the unknown vaccine safety and efficacy profiles. What we really are concerned about is potential for reduced immune responses. And so in these persons in particular, they need to follow all the current guidance to protect themselves from COVID-19. Pregnant women are another group that we've gotten a lot of questions about. We do know that pregnancy, there is a risk for severe illness in pregnant women. There might also be an increased risk for adverse pregnancy-related outcomes, such as preterm delivery. This is for COVID disease. We have no data or very few data to support the safety of COVID vaccines in pregnancy, but we know there's a risk for increased risk for disease. So we do have some limited animal data that is very supportive of the safety of vaccination in pregnancy, and we are following thousands of vaccinated pregnant women who have recently been vaccinated to look at both outcomes as well as efficacy and safety in the pregnant women. So we recommend if a woman is pregnant who is recommended to receive the COVID vaccine, she may choose to be vaccinated, and that's really a personal decision in discussion with her doctors and her families and her risk versus benefit. So considerations when making this decision include the level of COVID-19 community transmission, which we know right now is incredibly high, her personal risk of contracting COVID-19 by occupation or other activities, risks of COVID disease to her, and the lack of data about the vaccine during pregnancy. I'll quickly go through the contraindications and talk about the anaphylaxis issues. So prescribing information for both the Pfizer and the Moderna COVID-19 vaccines has as a contraindication a severe allergic reaction, anaphylaxis, to any component of these vaccines. We also, in the prescribing information for both of these products, appropriate medical treatment used to manage immediate allergic reactions must be immediately available in the event of an acute allergic reaction following vaccination. Cases of anaphylaxis have been reported. I apologize, this has not been updated. At this point, we've seen 29 cases in the United States, and this is in the context of over 5 million doses administered. So what we're seeing is about 1 case per 100,000 is being reported. And compared to flu vaccine, that's 1 case of anaphylaxis in about 1.13 million vaccines administered. Most of these reactions have been to Pfizer vaccine, but I would consider this to be equal for both vaccines. We are looking at data from Moderna vaccine right now and anticipate in the next week we'll understand if there's a difference. But in all of these cases, there's rapid onset following vaccination, and only 1 person had a prior history of anaphylaxis to rabies vaccine. A couple individuals did have histories of anaphylaxis to other things. So the precautions to vaccination, so a history of severe allergic reaction to any injectable therapy should be a precaution. These persons should be receive vaccination, but they should be counseled about the unknown risks of developing a severe related allergic reaction against the benefits of vaccination. In general, we feel like there's still a benefit of vaccination, and sites are prepared to watch all individuals for 15 or 30 minutes, depending on their risk for anaphylaxis. If they've had a history of severe allergic reaction, they should be watched for 30 minutes. But we do recommend and support these individuals being vaccinated. This talks a little bit about the recommended observation time after vaccination. And we do have interim guidance to identify persons with contraindications and precautions to vaccination seen here. So key messages for the potential management of anaphylaxis at COVID-19 vaccination sites are early recognition of symptoms, prompt treatment with epinephrine, and activation of emergency medical systems. I know my time is running low, so I'm going to just tell everybody that we have very strong safety systems in place to monitor COVID vaccine, including vSafe, for which we already have hundreds of thousands of people enrolled. This is a system, we call it the after vaccination health checker, where people are being encouraged to report adverse events and then are being followed up with a call if it's a medically significant adverse event. We need all of your support to help individuals enroll in vSafe, promote reporting through our vaccine adverse event reporting system, and communicate with all of your partners and patients on vaccine safety. So this is an exciting and historic time. The work is far, far from over. We've seen unanticipated challenges, or anticipated but challenges such as vaccine demand we're finding to be even more challenging than we anticipated. And we are working with everyone to find solutions and overcome these obstacles. Vaccinations are a really important tool, but we need to remind people to continue to wear masks, socially distance, and wash their hands. We are updating guidance this week around quarantining and the need to quarantine after vaccination. We are reducing that requirement. But community engagement is critical, and we want everyone to engage in conversations with their community and support individuals choosing to get vaccinated when it's their turn. And we have lots of resources available on the CDC website. We are happy to send this out later. And that's it. Thank you.
All right. Thank you very much, Dr. Cohn. That was an excellent overview. And we're getting a ton of questions for you. So considering your pediatric background, I'd like to start with a pediatric question. So Mark Goodwin is wondering about his 9-year-old, whether they'll be able to go to summer camp this year. So the question is, when will pediatric vaccines be available? And I think Mike Taigman had the same question. Can you comment on that?
Yes, this is something that I am desperate personally to also see so that my kids can go to camp this summer. Right now, the Pfizer vaccine is recommended down to age 16. So I am at least reassured that my kids will be able to go to college next year, my older ones. These companies are both doing age de-escalation studies rapidly, and those are ongoing right now. I anticipate that this age will be lowered in the coming months, likely starting in March. Is my current understanding and estimate, but it's not going to be all the way down to babies, obviously, right away. I think first it'll go down to 12 and then hopefully to 5 or 6. I am hoping that is before the summer. I strongly believe it will go down to some age, but I don't know how low that age will be by the summer.
All right, so stay tuned. Thank you. And next question is from Keith Lewis. This is a skilled nursing facility question. So is the vaccine effective if the patient only receives 1 dose? And the reason for asking is Keith works in a SNF, a skilled nursing facility, and a lot of their short-term residents are discharged prior to receiving the 2nd dose.
Yes, this is also an excellent question that we are updating in our clinical guidance. We are trying to update our clinical guidance based on all the questions we're receiving. We recommend that short-term residents and frankly, short-term staff go ahead and get their first dose of vaccine. There are limited data to support very good short-term efficacy of these vaccines. We have data between doses that these vaccines, depending on how the data are analyzed, are over 50% effective and maybe even closer to 70 or 80. But that's just for a few weeks after vaccination. So we absolutely think that it is better to get 1 dose than 0 doses. However, at the same time, it is very important for those individuals to get their second dose, and we are hoping that jurisdictions will put into place some way to capture those individuals who are discharged, so that even if they don't get it right at 21 or 28 days, that they get it very soon after in the community.
Okay, thank you. And then Dr. Cohn, you showed a slide that was going over the data for how many vaccines have been distributed, how many have been administered. There's a question from Erica Gartner. Is there any data being reported and tracked on the amount of wasted vaccinations?
We are capturing that data, and we do anticipate being able to report that data. In the next week, we will be able to report a lot more information. I would say by the end of next week, maybe beginning of the following. We are hoping to be able to report wastage, as well as product-specific administration data, and first dose, second dose administration data. It has been, we've done a lot in the months to prepare to get all this data, and we are working to be able to make sure that we're giving accurate data. There's also a lot of data on race and ethnicity that we're hoping to be able to report soon. But we are still, some of these data are not coming in as cleanly as we would like. So there's a little more work to do.
All right, thank you, Amanda. And Sanjeev, over to you.
Thank you, Matt. And thank you, Dr. Cohn, for this great presentation. Really great to have you here. The question is about pregnancy. You know, there was data originally in the studies. Some women had early pregnancy and got the vaccine, and it appeared that the vaccine was safe there. But now, since the vaccine has come based on your recommendations, many pregnant women in late pregnancy have actually received the vaccine. And we know from the data, the original trial data, that there's fever is a major side effect, which is not good for a pregnant woman. And so the question is, what is the data that you're getting right now on these pregnant women regarding the people who are getting the second dose of the vaccine? What's happening right now? What's the emerging data on it? And also, should these people wait for the second dose after they deliver, or are you still saying give the second dose late in pregnancy?
Those are all also really good questions. So we have been able to enroll, I believe at this point, over 5,000 pregnant women at all stages of their pregnancy have been enrolled and are being monitored closely in like a pregnancy registry type of thing. This is very similar to what we did during Zika. The clinical trials only had about 20 pregnant women in each one, and as you say, they were very early. So we don't have data yet if on pregnancy second doses. And really at this point, we don't have, except for from the clinical trial, we know that there was increase in fever after the second dose. So we can anticipate that. Fortunately, a lot of those fevers were fairly low and weren't that long in duration. And so I think it goes back to that pregnant women consulting with her provider and thinking about where she's working, what her protections are at work, and make a decision about getting that next dose. I strongly believe that having COVID in late pregnancy is far worse than getting the second dose of vaccine. And we do know there is some level of protection after the first dose, but we really, we don't have enough data to inform that decision right now. And we should have it soon, but we want so many people to get vaccinated. It's hard to, it will take a little bit of time for women to get data back on those late stage women in pregnancy.
Thank you, Dr. Cohn. You know, in many hospitals, including ours, to be a healthcare provider, you need to get the flu vaccine. You know, I can't go to work if I can't just say that, look, I'm not going to get the flu vaccine. Sorry, I opt out. Whereas we know for COVID-19, as many as 50% of the nurses and many doctors are opting out of this vaccine. Certainly, a physician or a nurse who gets this COVID-19 poses a risk to patients that they see. Why is it that COVID-19 is different from the influenza, for example, where this is a public health emergency, and why are they not why are we all not being forced, essentially mandated to get the COVID-19 vaccine for the public good?
Yeah, that is a really complicated issue. So the first thing I'll say is that these vaccines are authorized under an emergency use authorization. They are not licensed products. I have reviewed all of the data extensively, as have 2 advisory committees and multiple other staff at FDA and CDC. And the data from these clinical trials is incredibly robust. In fact, potentially, given the short time of follow-up, except for the short time of follow-up, more robust than many other clinical trials. But it is still authorized under an emergency use authorization, which, mandating use of vaccine, it is allowed at the local level or at a hospital level. It is not disallowed by law. But I think it's really hard to mandate a vaccine that inherently requires consent to get. It doesn't make you sign. In an EUA situation, you don't have to sign consent, but you should be understanding that this is being given under an EUA. Our hope was that with the huge amount of effort on education and engagement with healthcare workers, that that places wouldn't have to mandate it. Mandates are incredibly challenging, even with flu vaccine. And so with COVID, I think it would just be, I in some ways think it would be a distraction, as opposed to just continuing to meet with staff and trying to get them to understand the benefits of vaccination. The other approach that I think is important is to actually get vaccine in staff's communities, because I think if faith-based leaders and older adults in their communities start to get vaccinated and they see that it is being given safely, and how people feel so relieved after getting vaccinated, that will support uptake as well. But I think that, I mean, clearly our efforts to educate and promote vaccination are running up against really large issues around misinformation and just people being scared, honestly. When I talk to CNAs, people don't know what to do. So I personally think that we need to do everything we can to support vaccination, short of a mandate, but it really, hospitals and local health authorities can make that decision to mandate.
Are there any difference in the side effects between the Moderna and the Pfizer vaccine?
Very few. It's hard to compare side effects. So when I look at side effects between the 2 vaccines, I actually say there are no differences. And partially it's because of the populations that were the Pfizer vaccine. They both identified their populations differently. Pfizer was a global vaccine program. Moderna's was all in the US. And additionally, from a side effect profile, the way that they defined some of their side effects was different. The one side effect, you could argue there, it appears that there is more reactogenicity with the Moderna dose after the 2nd dose compared to the Pfizer one, but it's very slight. It's more people have low-grade fevers, and but it's really hard to compare the percentage, but it does appear that there are more.
Thank you, Dr. Cohen. Over to you, Matt.
Okay, thank you. I want to thank the network. We're getting some great questions here. The next one I'm going to ask is from an anonymous attendee. How long after someone has had COVID do you recommend they wait before getting the vaccine?
Yeah, so in our current guidance, there is no amount of time you need to wait unless you've received monoclonal antibodies. You can get COVID vaccine anytime. However, we do know that individuals who have had COVID are protected for at least 90 days, and there's emerging evidence even showing that you're protected for 180 days. And so in terms of vaccine prioritization, we would recommend now deferring vaccination if you've already had it so that other people can get these doses, frankly. There is also some, we are evaluating emerging reports about people who have had COVID seem to have increased reactogenicity to the first vaccine dose compared to people who have not previously had COVID. This is still anecdotal. We're doing a rapid evaluation of this issue. It does not appear to be substantial side effects, but there's side effects, but not serious. And so we are looking at that, and if that's real, we might change that guidance about time since COVID. But that would not be terribly surprising, given that having had COVID in the past already prepares your immune system. It's almost like getting that second dose, your first dose. So I think in the coming weeks, we'll have some additional information on that.
Okay, great. Thank you, Dr. Cohn. And you alluded to antibody infusion. A couple people are asking about the timing, if you've received an antibody infusion before you can be vaccinated.
Yeah, so right now, that timing is you should not receive vaccine for 90 days. That actually is also something that we're rapidly, we're working and talking to FDA about some of their data. It appears that we can shorten that time as well. But certainly if you've gotten antibodies in the past 30 days, you can very well assume you're protected. And so I don't think you would need to get vaccinated at this time.
Great, okay. Next question is from Ava Angeli. So for individuals on immunosuppressive medications, which, if any, should be held prior to vaccination in order to allow a robust immune response?
Yeah, so that is, there are so many different monoclonal antibody type immunosuppressants. We don't currently have specific guidance around that. That is really a discussion that we recommend people have with their providers who are giving those antibodies. It is about effectiveness and not a safety issue from our perspective. And I think it depends on the type of monoclonal antibody you're getting. People who are undergoing chemotherapy in immunosuppressed from chemotherapeutic drugs, that is also should be discussed with their provider. Our hope is that individuals who are on these types of medications have more frequent connectivity to their healthcare providers and can work with them to determine the best way to provide those medications around vaccination.
Great, okay, thank you. And let's see, a question from Melvina McCabe. Some patients are experiencing anaphylaxis greater than 30 minutes after the vaccine. What are CDC's recommended strategies for those who leave the vaccination site and don't have ready access to emergency services, such as those in rural communities, tribal nations, and so forth?
Yeah, so I think I have heard I don't remember any cases of anaphylaxis that have been confirmed being longer, maybe one or two cases, but most all of them are captured in that first 30 minutes. And I'll have to go back and get you a better answer to that question. We are trying to make sure that all vaccine administration sites have the appropriate treatment, including EpiPens, pulse ox, ability to address anaphylaxis and then call EMS quickly. Of course, if anyone has anaphylaxis at any time when they're exposed to anything, the most important thing for them to do is to call 911. And 911 providers do have epinephrine available to give. But if there is concern about an individual having anaphylaxis and going very, very far away from any potential EMS services, then my personal recommendation would be to watch that individual for longer.
Great. Okay, thank you. And sounds like it's fortunately would be exceedingly uncommon. Well, great. Over to you, Sanjeev.
Thank you, Matt. Minakshi Patel from Ohio has this question regarding when will we get more vaccines? And it has to do with this issue of, as you're saying, there were a lot of vaccine delivered, but it's not been distributed yet because of the second dose phenomenon. So the question, whereas the Biden administration is saying they want to get it all out, but they feel that there is enough vaccine in the background for the second doses. And there is, of course, this whole commentary about, recent commentary about why not just give everybody one dose for a greater public health benefit. I was just wondering, what is the CDC position on this? And what are you currently recommending? And what do you expect is how much vaccine will be available when in the United States?
Okay, great. So I'll answer your second to last question first, which is that CDC and FDA both strongly do not believe that these vaccines should be given outside of the EUA conditions of use, which include providing all individuals both doses and within that time frame, and giving the full dose. I've also heard people talking about half doses, and we don't have any data to support any of those other administration strategies. And so we do not recommend either of those things. Now, it's a different question around how many of the 50% of doses that are being held back, how many of those can you distribute? Because that's really looking ahead at how many doses we know are coming down the pipeline. It was always the intention that after about 4 weeks, we would have a better sense and reassuredness about supply coming in from the manufacturers, which I think we do. And so I think that the right answer is there's a sweet spot between making sure we have enough doses so that if there is an entire line of vaccine that can't be delivered by a manufacturer, we have backup. But 50% one-to-one backup is likely incredibly, is very conservative. So I think there's an in-between. Now, what people should understand, though, is at the same time, we're going to start delivering those second doses already. So when we start getting out those additional doses, it may appear that there's, we only have, that 50% doesn't translate to that many doses, frankly. It's, 5 million doses or 6 million doses. But once we get those out, it's a steady state again. So it's not 5 or 6 million doses a week that we're holding back. If that makes sense, because we're sending out second doses now too. So I think that that's something, people just need to remember. And finally, we need to pick up vaccine administration rates, and I anticipate that there will be a lot of things coming out in the next couple of weeks where we will both try to ensure that as many doses as possible are getting into arms, as well as maintaining health equity. And this is, we can get vaccine in people's arms. They're just not necessarily going to be the people who are at most risk for COVID, and the people who may have the most mistrust of government or mistrust of public health. And so we have to be doing both at the same time. And we are working on some strategies that I think in the next few weeks we'll be hearing more about. I know I'm saying that to a lot of things, but.
Well, thank you. The question is from Pauline Taylor and Tammy McGlone both from Pennsylvania. When will, looking for an estimated timeline when the general doctor in the community will have this vaccine in the office? It also relates to this issue of, there are people who are saying we got their first dose and now they've moved to another area. How do they get the second dose?
Right. So I didn't actually respond to the end of your other question, which is how many doses do we anticipate are going to be available? We do believe that we have a steady stream of about 4 million doses, give or take. It's somewhere between 3 and 5 for each of the vaccines. I think about 8 million doses a week is how thinking about it. So we will, but that even, so thinking that everyone needs 2 doses, that's not getting us to the number of doses, that ends up being more about 16 to 20 million people a month getting vaccinated, right? It's not enough. We do have potentially another product. There's 2 products that currently may have EUAs considered in the month of February or March. If we can get another one in February, that would exceedingly expand our capacity. The AstraZeneca vaccine in particular has an ability to make a large quantity of doses. And that leads to the second question: when can we get it in providers' offices? I do anticipate that will be in the spring. I think the first expansion that we'll likely see is getting it out to pharmacies more broadly. And we are enrolling, we are trying to get adult providers, especially large healthcare systems, I think will soon roll out. The problem is right now, you have to be able to deliver more than 100 doses in a 30-day period with these current products. The upcoming products have more flexibility in terms of their storage and handling. And so small providers that are unable to vaccinate 100 individuals may have challenges with these vaccines. They have to be able to assure that they can get out those doses. I think healthcare providers are an untapped way to get doses in people's arms. And I think as soon as we once again sort of feel like we've saturated these current administration sites, to me, that is the next obvious step.
I think when you're talking about the new vaccines coming in, at least looking at the raw data, it appears that because the numbers are so large, right, in each of these trials, that they are less effective than the mRNA vaccines. This is likely to create an ethical issue for the health system as to who will get the less effective vaccine and who will get the more effective vaccine, unless you feel that these statistics, that these data is not representative of actual efficacy. How do you plan to handle that when these new vaccines come?
We do anticipate these are 1-dose vaccines, not 2-dose vaccines, which is one benefit. But we do anticipate that there may be, the mRNA vaccines just way overmet our expectations in terms of efficacy. It's just, they're amazing. But we do anticipate that other vaccines may not, and they may be more in the range of 70% effective. One strategy that we're looking at, and we're trying to look at modeling to see sort of looking at how to prevent the most amount of disease, potentially reduce transmission, is to give healthier, younger individuals these 1-dose 70% vaccines, like kids going to college and things like that, but persons who have substantial underlying medical conditions and older adults, the 2-dose series. And that's, I'm just saying that as an option. I'm not saying that that's what is going to happen. But that, I think that the Advisory Committee on Immunization Practices has an ethical framework that they're using when they think about recommendations. And, this is going to be a huge challenge that will hopefully have a lot of open, transparent discussions around both equity and ethics.
Thank you. Over to you, Matt.
All right, thank you. Thank you, Dr. Cohen, for sharing this information with us, and thank you to everyone for all these wonderful questions. We do have more time built in for discussion, so we'll get to further questions later in the session. We're going to move on now to vaccine hesitancy, and this will be presented by Dr. Ayesha Khan. A little more background on Dr. Khan. She's a postdoctoral fellow in infectious diseases at UT Health in Houston, and is studying antimicrobial resistance in the laboratory of Dr. Cesar Arias. And Dr. Khan obtained her PhD from UT Health and MD Anderson Cancer Center in 2020, and bachelor's in microbiology and global studies with a focus on public policy from the University of California, UCLA, in 2015. She is pursuing a fellowship in medical microbiology and hopes to be at the intersection of innovative research in AMR diagnostics and personalized patient care. Dr. Khan was born in Bangalore, India, in an impoverished neighborhood where infectious diseases govern many facets of daily life. Growing up in 10 countries, from Russia to Saudi Arabia, she saw that infectious diseases were a macroscopic inequity that manifested through microscopic germs. She serves as the president of the American Society for Microbiology at Texas Medical Center chapter and ASM National's Texas Young Ambassador. So thank you very much, Dr. Khan, and over to you.
Thank you everyone for having me. Before I start sharing my screen, again, I think vaccine hesitancy is a important and unaddressed issue, though it's a massive, rapidly growing public health threat. And right now we're seeing the return of infectious diseases that we once eradicated with the introduction of vaccines like measles. So I think even outside of the context of COVID-19, it's something that we have tried for a long time now to do better at, in terms of the biomedical community at least, addressing it. I'm gonna start sharing slides. There's going to be, they're accessible later. So some of them are just going to be images that I want you all to be able to see. And it's okay if you're not able to read everything on the slides. It's supposed to be just a visual. Sorry about that. There we go. All right. So when we're talking about public health and how it's shifted in the last century, we're mostly talking about the causes of death that have drastically changed within, I don't know why it's doing that. I'm gonna keep holding it here. The causes of death, why they've shifted dramatically. So when we're looking at the 1900s, and this is pretty much consistent throughout the early, part of the 20th and the 21st century, that infectious diseases were the #1 cause of death. And when we're looking at cancer, heart disease, and other, including, accidents, for example, those were much, much, much lower on the rung. And now we look at moving into the 2000s, that's dramatically shifted. So that's the green that we're seeing, which is infectious diseases. And now it's more overtaken with cancer and cardiovascular disease, stroke, et cetera. And why that is important. So essentially, largely the innovation that we're seeing and what we're seeing in terms of why we have this dramatic shift is, let me see if I can move this. There we go. Is largely because there's been a drastic introduction of innovation. And what we're seeing here is crude death rate for infectious diseases in the United States. And this is specific to the United States, and I will actually address global facets as well, over the 1900s down to 2000. And what we're seeing is clearly, there's a drastic decrease in the number of people that are dying because of it. And it's a combination of first, us understanding what's causing infectious diseases. So that started a whole field of study, which I now specialize in, but also rapid introduction of simple innovation like sanitation and hygiene, but also vaccines and antibiotics that really changed the game. So when we look at vaccine hesitancy, I think there is importance of looking at the nuances in why people are hesitant about vaccines. And hopefully understanding that there are two overarching categories of people when we talk about vaccine hesitancy. So one of those is Black, Indigenous, and other communities of color that I believe have a justified valid mistrust. And then one is a anti-vaccine movement that people might be familiar with, that is largely led by higher socioeconomic groups and people that are privileged. And it is a manifestation of privilege. And understanding those nuances is ultimately really important to sustain long-term change. So when we're looking at COVID-19 itself, I'm going to shift away from vaccines because I think COVID has been a great example of us understanding what the problem really is. So this is just age-adjusted mortality count when we're looking through what is really the toll on communities of color. And as you can see, Black and Indigenous communities have the highest death tolls. And when we're looking at the geographic distribution, I'm going to show you a bunch of maps, and it's going to be faster, but I just want you to look at the overall pattern. So essentially, where on the map are things darker and where are they lighter, right? Darker means higher rates, lighter means slower rates. So when we're looking at cases, for example, a lot more cases in specific geographic areas. And when we're looking at COVID-19 deaths, similar geographic distribution, right? And why that is, at least medically, right? If we go into why certain people are exposed and certain people have higher risk, it's because when we look at the geographic distribution of people that do have higher rates of pre-existing conditions for COVID-19, that starts to make sense. And one of them is, for example, cardiovascular disease. And if you look at the geographic distribution of heart disease's death rates, very similar, right? And same for some of the other comorbidities like diabetes and obesity. And however, though, when we're looking at this distribution of which part of the country is really hit the hardest, it's not really restricted to just COVID-19 or infectious diseases. So this is the same geographic distribution that we see when it comes to infant mortality and maternal mortality rates after live births. And that is something that brings me to why is this really happening? And I think this is really relevant to everyone that's here that's not in the United States, that still, when we look at the top, highest causes of death and this is 2016, but largely hasn't shifted much. If we start looking at upper income countries, and these are like the United States, we're looking at, heart disease, stroke, pulmonary disease, and anything that's infectious diseases is a red bar. And everything else that's a non-communicable disease, it's a blue bar. And again, this is important. So looking at upper income countries, right? So once we start to look at lower income countries, but lower middle, and this is important because these are countries that have slightly higher GDP rates. And what we're seeing is this resurgence of the red bar, which is just different types of infectious diseases start to be a bigger problem. And when we're looking at low income countries, and these are countries that we now, in the aftermath of 20th century colonialism call developing, are clearly still dealing with the exact same problem that we were looking at in the United States in the 1900s, right? Which is that infectious diseases are the #1 cause of death by far. And this is supposed to show us clearly that there is something here in terms of inequity and how that's a driving factor for who gets sick and why. And I think that's really important when we come down to talking about back again to the United States, right, from a global perspective, that not everyone has that same reality here when we talk about what's developed and developing, because the history of what we're looking at is that, America is built on colonization and indigenous genocide and the enslavement of Black people. And that demographic shift and that legacy of what that looks like geographically is very important, because the communities that are hit the hardest are communities of color here. And when you focus on those communities, the causes of death look very similar to when we're talking about quote unquote developing countries. And that's because we're still living that reality and we're still there in America. And I think that's really important for us to understand. Because now when we start to shift and look at not necessarily health in the typical way, but also social determinants of health, right? Income. And what does poverty look like? The geographic distribution, quick snapshot. You can see it's pretty much overlapping with what we saw before. When we look at who's insured and uninsured, again, very similar geographic distribution. Percent of people without a high school diploma, right? Education, same distribution. So this is when we're, I think, starting to understand the reality on the ground. And this isn't just a historical issue, right? So we're looking at modern and reintroduced or introduced new ways of state-sanctioned violence that communities are exposed to. So we're looking at, for example, incarceration rates or immigrant detention facilities and the geographic distribution there when we look at the overlaps with COVID. So again, a lot of this, even though we can talk about it in a way where we're focusing on why people are sicker, right? So people talk about obesity and diabetes, for example. And sure, the geographic distribution, looking at that is very similar. But then side by side, when you look at, for example, low-income households that are more than a mile away from a grocery store, so that's accessibility to even have access to that kind of what we talk about is so easy, right? Lifestyle, things like that. Again, there's overlaps and food insecurity. So these are households that don't have a car and also are located more than a mile from a grocery store. So now we're introducing these important contexts that are usually lost when we talk about these pre-existing conditions or chronic illnesses that do lead to increased susceptibility to infectious diseases. So now I'm going to show that same exact map that I showed at the beginning, which is, again, these are COVID-19 cases distributed around the country, and side by side show a map of what the country looks like when we break it up into largest racial and ethnic groups that are living within a specific geographic region, concentrated or dense. And this is exactly the reality that we're seeing on the ground when we look at underserved communities or marginalized at-risk communities, that segregation and inequitable income, education, healthcare, and access are the biggest problem. The South is very much still the South. And that's, again, something that is so important for us to understand if we're really going to do something about vaccine hesitancy, because how we talk about the problem is really important. And again, I'm phrasing this according to COVID because it's, sometimes easier to talk about the things that are like really emergent. So people say race is a risk factor for XYZ disease. And this is a very common thing. That's how we talk about it in the biomedical field, that race is a risk factor for this disease, that disease, but that's not really accurate, nor is it helpful. It's because racism is something very specific that is a risk factor for COVID-19. And what we're ignoring when we're not talking about that is the root cause of these inequities. COVID-19 infection and mortality rates are in fact higher in Black, Indigenous, and other communities of color, which is a fact. But it's not because their race is a risk factor. It's because more marginalized communities are exposed to COVID-19. Again, this is a result of employment, or dense urban segregated neighborhoods. And they also face a greater burden of chronic diseases like we just saw with obesity, diabetes, cardiovascular disease, both of which are manifestations of systemic racism, right? Like generations and centuries of being exposed to trauma and oppression. And what that really does, which is epigenetics, it does take a toll on physical and mental health, and community health and public health ultimately. So instead of talking about things the way that we're normally used to talking about as healthcare providers and scientists, which is, we talk about how Black women are more likely to die after childbirth. That is a fact. Black newborn babies are 3 times more likely to die as well. That is a fact. But again, that makes it sound as though it's something about being Black, as opposed to the fact that there are studies, high impact studies that have shown that white doctors are more likely to think that Black people are more tolerant to pain, which is again a fallacy that is not accurate. And that is a result of historical studies that have falsely, falsified information to lead to this racist narrative. And when it comes to newborns, a really recent study showed that Black newborns are actually 3 times more likely to die if they're cared for by white doctors, and more likely to survive if they're cared for by Black doctors. So we talk about, again, the legacy of maternal health. I think really quickly to mention maternal health, gynecology. We never talk about really what the core of the issue is and where a lot of these problems start and where they come from. And if people might be familiar with a physician, slave owner as well, Marion Sims, who developed a important gynecological technique, surgical technique for the repair of vesicovaginal fistulas by experimenting on Black women without anesthesia, even though it was available. And is till this day hailed as the modern, father of obstetrics and gynecology. So that is the gap here. And that's what we're not doing a justice in terms of addressing why communities feel this way. And again, people might be familiar with Tuskegee syphilis study, which was an example of medical mistreatment and torture, where hundreds of Black men were recruited into a study, Black men with syphilis, and intentionally not told that there wouldn't be treatment given. And at the time, penicillin, which is the first antibiotic that was ever invented, was a cure for syphilis, intentionally was kept away from them so they could watch the progression of the disease. So that is the problem. And we've led to this cycle go on for so long that we haven't understood that modern and historical racism both have systematically created these inequities, that we are creating poor health outcomes for Black, Indigenous folks in this country. And that includes us not talking about it as if we are part of the problem, because we are the problem. We are not external to the problem. And that is because a lot of the structures that are existing in our country today are still structures that are existing from when, where we started, right? So from the creation of this country, from the creation of when we had chattel slavery. That's the system of medicine and academia and healthcare. That's still our foundation. That's how we started. And until we can really identify, confront, and abolish those root causes of health inequity, which is structural racism and classism, we're not going to be able to make any leap, because we're still very much living in this dichotomy of what the problem is. And I'll end very, very briefly, switching back to my face. And I think when we talk about what do we do about this, that is a important thing to address, and how do we move forward? And I think one thing that I've learned is accessibility, and how accessible we are as the biomedical community at talking about issues, whether it's COVID-19 or vaccine hesitancy, is extremely important, because throwing piles of data at marginalized communities who already have not been provided basic resources, and we're in a state where we don't have, we're in a country where we don't really have infrastructure to have systematic public outreach, where communities are getting reliable information, rural communities, for example, that going in and having this excessive scientific jargon, things like that, is already creating this block. So what I've tried to do is focus on accessibility, focus on talking about it without any scientific jargon, focus on talking about this exactly, the history, acknowledging that there's this justified mistrust, and it's not because they are falsely, just doubtful of the healthcare system, but that the healthcare system is not trustworthy. And talking about it that way, surprisingly, is able to break this barrier where it's a me versus, us versus them dynamic. And it creates an understanding of we're doing the best we can, which is ultimately, I think, what we're all doing. And I think hopefully if we can kind of keep it focused on that and keep it focused on the accessibility part, I think that's when we can really start to communicate this information and address some of these questions. And I'll actually post my Instagram in the chat, because I think that's another important thing that a lot of healthcare providers can start doing, thinking about how we're communicating information and using platforms, because there's so many opportunities for us to be a lot more accessible to the everyday person than we take sometimes.
Right. Thank you, Dr. Khan, for that really excellent presentation on the roots of vaccine hesitancy. I'd like to introduce Dr. Loretta Christensen now, who is an enrolled member of the Navajo tribe and a native of Gallup, New Mexico. She is the CMO for the Navajo Area Indian Health Service, and has been the co-lead for the COVID-19 response branch and the lead for the medical branch of the Unified Command for Navajo. Dr. Christensen received her undergraduate degree in biological anthropology from Harvard University, and her medical degree from Hahnemann University Medical School, Drexel. She completed her general surgery residency at Monmouth Medical Center in New Jersey, and a fellowship in trauma and critical care at Cooper University Hospital. Dr. Christensen has an MBA from Georgian Court University and a master's in jurisprudence with a specialty in healthcare law from Seton Hall Law School. And Dr. Christensen will be discussing the Indian Health Service vaccination distribution plan. So thank you, Dr. Christensen.
Why, thank you. I'm going to pull up my slides for you all. It's a pleasure to be here this morning. I want to thank Dr. Khan for some absolutely excellent points, which makes what I'm going to say make very much more sense. So thank you so much. So Before we could even start vaccine planning, I'm sure many of you know, the Navajo Nation was struck very hard by COVID-19. Our first wave in April and May reached significant heights and sort of strained our healthcare system. And of note were all of the things that were pointed out previously, which is the lack of running water, our multi-generational homes, being a food desert in which we literally have 13 supermarkets in 27,000 square miles. So you can imagine the challenges we had. But knowing that there was a possibility of vaccines coming along was certainly reassuring to us that there was some hope down the line. So in our planning, we started very, very early as we did stand up our emergency operations in February. So we have been very progressive and very active. We reviewed, of course, the CDC playbook. Our headquarters IHS had a draft plan, which we carefully reviewed. And we used all the materials that were supplied by both CDC and IHS to distribute to all our facilities very, very early. This included pre-planning worksheets, which we then followed up on weekly with our service units and healthcare facilities. And we actually asked them to make assignments with names to organize their teams. The reason for this is we were very much trying to be thoughtful that this is going to happen. This isn't just something that you can plan on the fly, that we had to really put our time and organization into being ready for the arrival of the vaccine, which we were all depending on, if you will. So we actually asked them to make teams and to make it real and to practice with their teams so that we would be ready to go the second that the vaccines became available. We then tried to collaborate, and I say try, and we were very successful, and I'm very pleased with the collaboration, but there is a lot of differences amongst tribal urban organizations and federal organizations. As was pointed out in the previous talk, there is mistrust of the federal government that we battle on a daily basis out here in Navajo, as we're trying to work, collaborate, and care for all of our Dene, our Navajo people. There is still some mistrust. There is still some question about our intentions. So imagine now we're all thrown together and we're having to pull together as a group to organize for the coming of the vaccine. Well, it has gone extremely well. And I think the key to this is communication. Whatever differences we had with our, what we call 638 tribal organizations, which means they are self-determined and independent, seemed to disappear. They hadn't done very much with their vaccine planning and were very relieved when we said, join our calls, we're all going to work together. I'm happy to help you, support you, work with you to make sure your healthcare facilities are ready for the vaccine that is coming. And they all have been wonderful and worked very well with us. So we have area-wide calls with every single facility in Navajo. And remember, we span 3 states. We're in Utah, we're in Arizona, and we are in New Mexico. So we had calls with everyone. And again, the checklist, the pre-planning tools, I sent frequent information out to them. Our calls had 150 plus people on them, which meant people were interested, they were focused, and they wanted the information. We appointed our vaccine POC, who is my lead pharmacist for the area, and a data management POC, who is my lead for IT clinical applications for Navajo area, and does work with all facilities on Navajo. We also then took the time for our team to be on multiple subcommittee teams of the headquarters, so we could be apprised and on real time of what was going on at the CDC IHS level. Because we span 3 states, we also spent quite a bit of time on our state meeting calls, not knowing if all of our non-federal facilities would ask for distribution through IHS or they would go with the state distribution plans. We wanted to be ready and we wanted to understand what the states were doing, where our facilities are located, so that we could navigate well for all of our people. So in the end of this decision, all of the facilities in Navajo area, with the exception of Utah Navajo, which is located in the southeastern portion of Utah for the most part, they elected to distribute through Utah State. The remainder of all our facilities chose IHS. We had multiple calls with Navajo Nation leadership. As you know, they are sovereign, and we do definitely express their desires when we are making decisions, such as priority lists, such as what communications will be done, and how we're going to approach our distribution. So the president of Navajo Nation has been extremely active and very supportive of all of our efforts during this pandemic, with a very strong leadership into public health orders and communication with all of our people. We did finish a draft of our plan, which everyone had a copy of, and it's readily available to anyone who wanted to see it. And then we did a separate distribution plan because there was some changes back and forth, as you all know, during this process, where CDC initially said, you know, we would be distributing one way, and then there were some changes due to Pfizer needing to be shipped in the ultra-freeze state and having to receive that in a particular way. So we did redo our distribution plan, and we did a lot of public messaging for vaccines. Why do you need them? What do they mean? What are the side effects? Why you should get it? And any information we had, knowing this was also translated into Navajo, and a lot of our public messaging was culturally appropriate for our area. And it was, again, we use simple, straightforward language, but we do want to cover everything and be totally transparent. I feel in the past, when we've been dealing with federal and tribal interface, that has been key, is that how transparent we've become over time. And there is more trust than there used to be, but it has been a long road, and it's not one we're finished with. It is one we have to continuously work with to make sure our messaging is appropriate, culturally appropriate, and received. So we made multiple changes because there were, as you all know, many changes that would come about in the time right before the distribution. We updated with the CDC 2.0, and we reviewed our final plan from our headquarters. We had tabletop exercises for distribution and administration to make sure people were really focused on the actual processes that they would need, because we said we don't want to show up at your door with your vaccine and you're puzzled when we get there. We wanted to make sure that your team was finely tuned and that you knew what to do. So in all of this, we had multiple very in-depth discussions concerning the priorities, waiting on the final ACEP guidelines. Our tribe has adopted them, and that's been helpful to us because we have a clear guideline on what we're trying to do for our people in Navajo Nation. The only change so far that has been made is we did drop down to 65 and over with our 1B. Otherwise, we have followed the ACEP guidelines and follow them very, very closely. Now imagine a lot of you on these calls are in areas more rural than mine, and I think ours is, I call it extreme rurality at time, because to get things out across Navajo Nation takes quite an effort. We have 27,000 square miles, as I said before. There are very few roads to these places. We have one way to get there. So when we set up our distribution plan, it was very thoughtful. Our incident commander for Navajo area did an exceptional job. And we did many adaptations depending on what the delivery schedules were. So just to briefly tell you, our first doses arrived on 12/14 to Gallup Indian Medical Center, who has an ultra freezer. And we have established ultra freezers at 6 of our 9 receiving sites, which has been quite helpful. We used our 4 distribution teams, and we did use police escorts, knowing there is one route to each one of these facilities. We wanted to make sure we had a timely and safe travel. So I listed the places that we went to, and just to point out to you, Crown Point is one of our most eastern sites, and NACA, or Native Americans Community Action, is in Flagstaff. So we are talking 3.5 to 4 hours between our 2 extremes of our population facilities. So those were sent out and they got there very safely, and vaccinations were actually given on that first day at a couple of those sites. We got 2 more shipments at our other 2 facilities in Chinle, Arizona, and Northern Navajo Medical Center, which is in Shiprock, New Mexico. From there, 2 additional distribution teams with escorts went to Tuba City, which is also on our western border, and Kayenta, which is up near Utah in our most northwest corner of the Navajo Nation. So we did not have any damage to any vaccines. They were delivered safely, with proper temperatures and proper management of the handling of the vaccines. We had our pharmacist on the teams, and we had our emergency operations command were part of our distribution team. So what are our challenges? Well, they're the same as everyone else in the United States. We had constantly changing information from the vaccine companies, you know, the second dose, 2 days, 3 days, 5 days, back to 2 days. You can take them out of the container. No, you can't, you know, and we just adjusted as these guidances came out. CDC did make some changes in their guidance, and I know it is a dynamic and fluid process, and we understand that. The priorities with ACEP were a little bit late in the game, so we were waiting patiently for that just to make sure we were in accordance with that guidance. And then coordinating our priority groups with Safe Access. Where we do understand vaccine hesitancy, I don't think we have dealt with it a great deal on Navajo, for which I am very grateful, because people have suffered so badly during this. We have 5 times the mortality rate. We have 32,000 cases. For our very small population, we have been in the top 3 per 100,000 for quite some time. We don't have ICUs. We only have 16 to 20 ICU beds if we expand them. We are dependent on our tertiary centers. We have limited and finite bed capacity. So I think our people want to be well. I think they look at the vaccine as an opportunity of protection. We have had so many public health orders that have asked them to lock down, stay in place, shelter in place, that they are looking for something that will allow a change in that status, and they're willing and working with us for the vaccine. And in fact, we had a drive-through last week at Northern Navajo, which almost 1,800 people were vaccinated, and the lines were miles long to get in there. So that speaks very highly, I think, of us communicating well, talking about the vaccine, encouraging the vaccine, and certainly answering all questions about the vaccines for our Dene people. So where are we now? We have completed our 1A priorities. We are trying to work with an online registration so our data can be used to define our capacity. Our online registration will help us with business essential categories, as those aren't typically known to our healthcare facilities. And we want to be very transparent. So we have actually posted our priorities across Navajo Nation. We host live Facebook. We use the radio who speak fluent Navajo to help us get to our elders. This week for us is Elder Week. So we are focused on anyone 65 and over to come in and get vaccinated. We are giving appointments. We are having what we call mass vaccination events. And we are working in all these different ways to get our people taken care of. We estimate we have over 60,000 over 65 across Navajo Nation. So you can see our 1B is quite robust, and we're working very hard to keep this organized. In terms of health equity, we use prior historical equitable distribution percentages for our facilities. It was widely accepted. We've had no pushback. It uses the user population assigned to each healthcare facility to determine the percentage of vaccine. We are flexible, however, and if somebody finishes their priorities and we can shift vaccine to another population, we are carefully tracking this, and we intend to remain entirely equitable and transparent about our distribution. It's given to every facility so they know where all the vaccine is. They've worked extremely well together. They are storing vaccine for those without ultra freezers, and they're sharing when somebody runs low. So to this date, I'm very pleased with our progress. We've received 19,500 first doses, and we have given out 75% of that has been given, and we are almost finished with our second dose of our Pfizer vaccine, which is the first one that arrived here. So there are many challenges. We will have some people that are hesitant or anti-vax, as I say, but I think the vast majority realize this is a very important step for us to mitigate and control COVID. So thank you for this opportunity to talk to you today. And I appreciate all that you're doing in your communities to help our people and your people. Thank you so much.
Excellent. Thank you so much, Dr. Christensen. We're going to do a couple of live questions here. And the first question I'm going to direct to Dr. Khan. This is a question from Akwazi Ampansa. So why do you think that Africans in African nations and living in densely populated communities have lower COVID-19 infection rates compared to the United States?
So, I mean, I don't know like which specific country that would, I think, help. So I don't actually think that's entirely true. I think a lot of it is the lack of information that's disseminated in terms of what the reality is on the ground with a lot of these communities. I think we just don't really see the picture. But there are certainly, examples of countries, not just in the African continent, but also in Southeast Asia and South Asia, that have dealt with the entire pandemic response a lot better and have managed to cut down rates to none. And I think in that case, it's just Dr. Christensen actually just talked about it, which is just communication and coordination and leadership. I think it's a lot of what we think about America being, again, I think that's where the dichotomy of the developed developing is really meaningless for the most part, because the United States, though there is infrastructure here that could be possible to be able to coordinate this response, it really didn't happen. And I think that's because of all of the inequity that was clearly the reason for our failure. But in a lot of other countries, even though their GDP might be low, even though they're considered lower socioeconomic, they still do have, collectivist cultures. That's one thing that I think is really important, that they're community oriented, and it's very natural to them to prioritize the health and well-being of their neighbor and do whatever it takes to protect a community. That's kind of the culture that I came from, right? And also, I think just having community infrastructure to be able to talk to each other and disseminate information. I think it's something as simple as that.
Okay, great. Thank you, Dr. Khan. One more question, then I'll see if Dr. Aurora has another question as well. But this one I think is more for Dr. Cohn. Do we have and I'm combining a couple questions. Do we have a sense for how long the vaccine will be effective? So do we think this is a vaccine that we're going to need every year, like a flu vaccine, or is it a one-time deal?
We don't have a sense yet. We certainly anticipate that it could be more of a flu vaccine type of needed vaccine, and then hopefully we'll combine it with the flu vaccine very quickly. But we are rapidly doing those studies, and we have both the people in the original clinical trial who were at 6 months, about 5 months after getting both doses, and we are doing some large, rapid studies post authorization to inform the declining potential waning immunity.
And I think there is some information from a lot of times, because this is a ongoing, evolving, rapidly evolving field that really is moving the same time as the pandemic is moving. That a lot of these studies, that though we know, for example, that we do have protection for the duration of 5 to 6 months based on the clinical trial, we don't know how long that goes, but we do know from, for example, SARS, and that's again within the same family of viruses as SARS-CoV-2, that vaccine, like when they had eventually developed a vaccine and looked at least the limited data that they have, that immunity was up to 1 or 2 years. So that's like, we do have some sort of an idea of how, how this might look like, but again, every virus is its own thing. So
we also don't know what will happen to this virus epidemiologically in the next, over time. This is all new. So as Dr. Khan said, we'll take what we know and then figure it out as we know more.
All right, thank you, thank you. So we are at time, so to conclude today's session, I want to thank our presenters, Drs. Amanda Cohn, Dr. Loretta Christensen, Dr. Aisha Khan, for sharing their time and their expertise with us. Thank you for everyone on the network for joining us and being so engaged for today's ECHO COVID-19 Global Conversation session. There are still so many questions that we haven't gotten to, and I want to invite everyone to join us for our Global Learning Collaborative on February 1st, which will be moderated by Dr. Soumya Swaminathan, the Chief Scientist of the World Health Organization. And the topic is very much in the same vein, equitable global vaccine distribution. So please join us for that. You will find a link in the chat box to the registration for that event. You'll also find links for obtaining your CME credit and various resources that were discussed today during the session. Also, please watch your email for announcements and session updates and other information. And we will look forward to seeing everyone on February 1st. Thank you, everyone. Bye.